Hello everyone and welcome to our module on atherosclerosis. Let's start by defining some vocabulary. So the term arteriosclerosis refers to hardening of the arteries. If you dissected cadavers in the anatomy lab, you probably noticed that some of the cadavers, especially the ones from people who died at an older age, had very hard, stiff arteries. That's evidence of arteriosclerosis. And in the hypertension section, I talk about hyaline and hyperplastic arteriosclerosis, which are two subtypes that are associated with high blood pressure. But in this video, we're going to focus on atherosclerosis, which is a form of arteriosclerosis, and in fact, it's the most common type. And it refers to the buildup of plaque filled with lipids inside of arteries, like what's shown on the screen here, until the artery can become very narrow like this. So as I said, atherosclerosis refers to plaque accumulation in the walls of arteries. And there's lots of evidence that atherosclerosis is a chronic inflammatory process. In videos in the immunology section, I talk about chronic inflammation, and that process occurs in the walls of people affected by atherosclerosis. There's lots of cell types involved in atherosclerosis. In particular, there are macrophages, which we'll talk about in a little bit, and also T cells. And then you should know that atherosclerosis involves the accumulation of lipoproteins in the walls of arteries, especially LDL cholesterol. LDL is called the bad cholesterol, and it gets that nickname because it's found in the walls of arteries of people who have atherosclerosis. And atherosclerosis underlines many diseases, but the big ones are coronary disease like myocardial infarction, stroke, and also peripheral vascular disease. All of these things are caused by the buildup of plaque in the walls of arteries. So we're going to talk about the process of atherosclerosis developing over time, but here's a cartoon that depicts that process. It begins with a normal artery, and then the plaque begins to grow and accumulate until it can obstruct almost all of the vessel lumen. And you should know that when plaques accumulate in arteries in atherosclerosis, it's usually eccentric, like what's shown in this picture. In other words, there's more plaque on one side of the artery than the other. That's pretty typical for how atherosclerosis develops. And then here's a cross-section and a biopsy slide. This is the artery here, and it's been narrowed down to a very small lumen by the process of atherosclerosis. So before we go any further, let me review the typical structure of the artery wall. So there are three major structures in the wall of an artery. The first one is called the intima layer. It consists of a single layer of endothelial cells and a basement membrane. After that, you have this layer right here, which is called the media. It consists of smooth muscle cells and also proteins like elastin. And then finally, out here, you have the adventitia layer. This layer contains connective tissue. It also has structures called the vasa vasorum, which is the blood supply to the artery wall, and you can also find nerve fibers here. So these three layers are the major layers of the arterial wall throughout our body. You should also be aware that we broadly define arteries as being one of two types. The first type is called an elastic artery, and it gets its name because there's lots of elastin in the medial layer, and this allows the artery walls to stretch. So in systole, when the artery fills with blood, it will expand a little bit, and then as blood leaves the artery, in diastole, it will contract. And this is the type of artery you find in places like the aorta, in the carotid arteries, and also in the iliacs. The other type of arteries is a muscular artery. So these arteries have a layer of smooth muscle cells that allows them to vasoconstrict or vasodilate to modify blood flow. And this is the type of vessel you find in arterioles in particular. They're the smallest muscular vessels in the body, and because they're so small, when they constrict, they can almost completely cut off blood flow, and therefore they provide the most flow resistance. And I talk about this process of arterioles and flow resistance a lot in some of the cardiac physiology videos. So now that we've talked about that, I can tell you that the places where you most commonly find atherosclerosis are the large elastic arteries and the medium-sized muscular arteries. So in particular, it's common to find atherosclerosis in the aorta, especially the abdominal aorta, also the carotids and iliacs. And in terms of muscular arteries, you often find atherosclerosis in the coronary arteries. That's what leads to myocardial infarction, and also the popliteal vessels. Okay, so now let's talk about the pathogenesis of atherosclerosis. In other words, how do these plaques build up in artery walls? Well, the first thing to know is that we don't completely understand everything about how atherosclerosis develops. But there are some underlying principles that have been well characterized, and that's what I'm going to talk about in the next few slides. So the first thing that clearly seems to be necessary for atherosclerosis to occur is endothelial layer injury or dysfunction. Remember, the endothelial layer is that innermost layer of cells. How the dysfunction occurs, leading to the buildup of plaque, is incompletely understood, but it's believed that this element of the pathogenesis of atherosclerosis is related to risk factors. So it's believed that things like cigarette smoke or high blood pressure or high cholesterol, all of these things can damage the endothelial layer here, and that can lead to dysfunction and the development of plaque in the artery wall. Another important point about the pathogenesis of atherosclerosis comes from the fact that it commonly develops at branch points or vessel origins. The origins of vessels are also called the ostia of the vessel. These are very common sites for plaque, and it's believed that turbulent flow at branch points and vessel origins leads to endothelial stress, and that may be why these areas in the body so commonly develop atherosclerosis. This is a coronary angiogram on the screen here. So this is the ostia of the left main, which is this vessel right here. That's a common place to develop atherosclerosis. Over here, you've got the LAD and circumflex arteries coming off the left main. This branch point is a common location for atherosclerosis. So is the ostia of these two vessels right here. And this is believed to be due, as I said, to turbulent flow in these locations. Another key element of the development of atherosclerosis has to do with lipids. So like I said before, LDL accumulates in the plaques of atherosclerosis, especially in the intima layer. What's believed to occur is that LDL cholesterol particles become oxidized by free radicals, and then those oxidized particles are scavenged by macrophages, which fill up with lipids. These macrophages can't degrade the lipids, and so they become engulfed with lipids and turn into something known as foam cells. And this is a picture of what a foam cell looks like on the screen here. It's a lipid-laden macrophage. And then I mentioned this earlier, but chronic inflammation is an important element of the development of atherosclerosis. LDL gets oxidized by free radicals, as I said, and this causes damage to the endothelium and smooth muscle layers. And then macrophages come in to try and engulf the oxidized LDL, and they release cytokines. And the net result of all of this is chronic inflammation in the walls of arteries. And then the final element of the pathogenesis of atherosclerosis that we'll discuss has to do with smooth muscle cells. They proliferate in the intima layer in vessel walls that are affected by atherosclerosis, and they lay down lots of extracellular matrix. And this is an element of those plaques that build up in the artery wall. And this has been studied quite a bit in the basic science literature, and one of the key growth factors is platelet-derived growth factor, or PDGF. This is one of the major growth factors that leads to smooth muscle cell proliferation. This isn't really clinically relevant, but worth knowing this for your board exams. So shown on this slide is a cartoon of how atheroma or plaque grows and develops in the wall of an artery. So the process begins with foam cells. That's what's depicted right here. And remember, these are macrophages that have picked up those LDL cholesterol particles and become filled with lipids. The next phase in the growth of an atheroma is the development of what's known as a fatty streak. So the fatty streak contains lots and lots of macrophages filled with lipids, and they form a line or a streak along the vessel lumen. Now, this doesn't impair blood flow very much. It's a very minor lesion in the wall of the artery, but it's the first step in development of an atheroma. And you can find fatty streaks in children and adolescents, and not all of them progress. So every patient that has a severe atheroma in the wall of one of their arteries once had a fatty streak, but not everyone who has fatty streaks will go on to develop serious vascular disease. Okay, and then after the fatty streak phase, if the atheroma progresses, it'll go through an intermediate phase and then become an atheroma and a fibrous plaque. And in this stage, the main thing that's going on here is that the intima layer is getting very thick. That's what's shown here. It's starting to push into the lumen and obstruct blood flow. And also lots of lipids are beginning to accumulate in the plaque. That's what you see here in yellow. This process is usually patchy along the vessel wall. It rarely involves the entire vessel wall. It occurs in spots and places. And as I told you earlier, the growth is usually eccentric. So you can have one wall of the artery that's not affected at all or minimally affected, like what's shown here, and then another wall that's got a very thick plaque. That's what you see once the atheroma has sort of matured and become larger. And as it's shown in this picture here, this all takes a long time. So these first stages may be present for 10 years or so. It may take another couple of decades for this stage to occur. So this whole process develops over years and years and years inside the human body. And then what you fear is that this fibrous cap on top of the plaque can rupture. If that ruptures, that can be a nidus for blood clot formation, and then you can get a thrombus on top of it. And that's how people develop thrombosis on top of an arterial plaque, and they can develop a myocardial infarction or a stroke or critical limb ischemia. And so this is just another picture of that whole process. It starts with foam cells, becomes a fatty streak, develops into an atheroma and a fibrous plaque, and then you can have a complicated lesion where there's rupture of the plaque and thrombosis. And this is what leads to all these things here, like acute coronary syndromes, strokes, limb ischemia, etc. So in this page, I've listed the 5 locations that most commonly develop atherosclerotic plaques in descending order. So the most common spot for plaques to develop is the abdominal aorta. Now keep in mind, the abdominal aorta is a very large vessel. So if you look at it like this, it's very large, a couple centimeters in size. So even if a little bit of plaque builds up, that's very unlikely to obstruct flow. So the problem with plaque in the abdominal aorta is not blockage of blood flow, it's development of aneurysms, and we'll talk about that in a minute. The second most common spot is the coronary arteries. This can lead to angina and myocardial infarction. After that, it's the popliteal arteries, which is what leads to lower extremity vascular disease. This is followed by the internal carotid artery and the circle of Willis, and plaque in these locations can lead to strokes and TIAs. So now let's talk about the major complications of atherosclerotic plaque. We've touched on some of these already. So the first one is ischemia. If you have an artery like this and it's narrowed with plaque down to a little tiny lumen like what's here at the top, that's not enough area for blood flow and you will get decreased blood flow, and this is how people develop angina from coronary lesions. The second complication is plaque rupture, which I mentioned earlier. So when a plaque ruptures, like what's depicted in this cartoon here, that exposes thrombogenic substances in the plaque to the bloodstream and a clot can form. And this can cause acute vessel closure. That's how people get STEMIs, when one of the coronary arteries is acutely closed off from a clot. Also, the thrombus can embolize, and this is how you can get a stroke from a carotid plaque. It's not so much that the plaque is stuck in the carotid artery, it's that pieces of it are breaking off and traveling to the brain. Another complication that can occur is hemorrhage into the plaque. So if the fibrous cap overlying a plaque ruptures, blood can get into the plaque and it can expand rapidly and go from a very minor, small plaque to suddenly a big lesion obstructing much of the vessel. You can also get hemorrhage into the plaque another way. So in the periphery of these lesions, there are small blood vessels. That's because a process occurs called neovascularization. And so if one of these small vessels ruptures, that can also lead to hemorrhage into the plaque. And the clinical consequence of this is that a plaque that might only be obstructing 10 or 20% of the vessel lumen can suddenly expand and obstruct 80 or 90%. That's because there was a rupture and bleeding into the plaque. And then the final complication to know about is aneurysm. So these lesions can damage the underlying medial layer, and then the artery wall can start to bulge out. And this is extremely common in the abdominal aorta. So this is a picture of that right here. This is an aneurysm right here. And this is a consequence of atherosclerosis. It's not that the plaque has obstructed blood flow in the aorta. It's a big vessel that's very unlikely to happen. But the plaque has made the wall weak, and now it's expanding outwards. And if it ruptures, that can lead to hemorrhage and sudden death. In the immunology section, I talk about dystrophic calcification, which is the deposition of calcium that can occur in places where there's chronic inflammation. And you can see dystrophic calcification in atheromas. It results from the chronic inflammatory process that's occurring in the walls of the blood vessels. And the fact that calcium gets laid down where there is atherosclerosis is the basis for coronary CT scans, which are sometimes used to detect coronary disease in patients by looking for calcium. So this is a coronary CT scan shown here on the screen. This is the aorta right here, and this is the LAD artery. And you can see that the LAD artery has white in it. That means there's calcium in the wall of the artery, and that tells you that there is coronary artery disease there. It doesn't tell you how severe it is. It could be a very mild plaque of 10%, or it could be a severe plaque. But nevertheless, the CT scan shows you evidence of coronary disease and atherosclerosis by detecting the dystrophic calcification. So I'll finish this video by talking about infarction, which is a related topic to atherosclerosis. It's often a consequence of atherosclerotic plaques. So an infarction is an area of ischemic necrosis inside a tissue bed or an organ. And there are 2 major types, white and red infarcts. So let's talk about the white infarcts first. This occurs when a plaque or a thrombus on top of a plaque occludes the arterial supply to a solid organ. You often see this in organs like the heart and the kidneys and the spleen, where there's vascular disease present that cuts off the arterial supply. When there's limited blood supply from healthy tissue nearby, the tissue will then become pale or white from the infarction. And so that's the definition of a white infarct: no blood flow and no blood leaking in from neighboring healthy tissue. So here's a cartoon depiction of a white infarct in a solid organ. Usually these are very obvious when you look at a solid organ in gross pathology. There'll be a large area that is white or pale. And then the other type of infarct is a red infarct, sometimes also called a hemorrhagic infarct because it's blood that turns the infarct red. This is a picture of a red infarct in the lungs right here. You can see how this wedge-shaped area of tissue is darker or redder than the surrounding tissue. And this is what happens when you get ischemic necrosis, but blood is able to enter the ischemic tissue. So there's a couple of classic scenarios that lead to red infarcts. One of those is testicular torsion. So I talk about this in videos in the reproductive section, but when you have testicular torsion, there's blockage of venous drainage. So the testicles become ischemic, but they're engorged with blood because there's no venous outflow, and that can lead to areas of red infarction. The other place where you can get red infarcts are in tissues with a dual blood supply. So blood flow from the second supply floods the ischemic area with blood turning it red. So the classic example is the lung, like what's shown in this picture here. It has a diffuse blood supply. So if you have a lung infarction, that can lead to red infarcts. You can also often see this in the small intestine, which I talk about in the GI section, but many areas of the small intestine have a dual blood supply. Final example of where you can see this is when you reestablish flow to a necrotic area. So for example, if you perform angioplasty and you restore flow in a coronary artery, blood's going to flood into an ischemic area of the myocardium, and that can turn what would have been a white infarct into a red infarct because you've restored the blood flow. And that concludes our module on atherosclerosis.